This is part 3 of the videos, General Principles for Interpreting Immunogenicity. I hope that these 3 parts are standalone. You don't need to see the other 2, although I will be referring to the other 2. But in this particular one, I'm focusing on the actual clinical interpretation. So we sort of covered in general what was the general immunogenicity response. We have the innate system, we have the adaptive system, different kinds of responses in terms of the biology of responding to drugs. And then we also, in part 2, covered a little bit about what the assays are and how we can interpret the assays for anti-drug antibodies. So in this part, what we are going to cover is how do we interpret this in the clinical setting.
Avoid using opinions. As regards any subject we propose to investigate, we must inquire not what other people have thought. I'm going to read that again. We must inquire not what other people have thought, or what we ourselves conjecture, but what we can clearly and manifestly perceive by intuition or deduce with certainty. René Descartes, in the Rules for the Direction of the Mind, just in case your Latin is rusty, this is rule number 6, written between 1626 and 1628. What René Descartes is telling us is basically saying, let's try not to follow what people are saying just for the sake of it. Let's try to see the facts, analyze them, and deduce with certainty. Men have sought to make a world from their own conception and to draw from their own minds all the material which they employed. But if, instead of doing so, they had consulted experience and observation, they would have had the facts and not opinions to reason about. Basically, what Sir Francis Bacon, in The Great Instauration, published in 1620, is saying goes pretty much along the lines of what we first reviewed with René Descartes. And it is not just by chance that I chose these 2 quotes from contemporary authors of the time of illustration in Europe. This is a time when people were basically waking up in terms of thinking and not just follow what you are told and what you are told to believe. Make sure that you can have the facts, that you can have the different experimentation and data so you can draw all of the conclusions with a level of certainty. This is a list of some of the most common mistakes that I encourage you to avoid when interpreting immunogenicity. Immunogenicity equals anti-drug antibody test results. I've seen this written many different ways, but basically the most typical statement is if there are no anti-drug antibodies, the drug is not immunogenic. The anti-drug antibody assay provides unequivocal positive or negative results. Anti-drug antibodies always interfere with PK. You can see it written as if the PK is not decreased, there are no anti-drug antibodies in the samples. In other words, let's not waste money and time in testing them because everything is okay with PK. If anti-drug antibodies interfere with PK, it is always in one direction. In other words, people say anti-drug antibodies can only decrease the PK. Anti-drug antibodies always interfere with function. Another way of looking at this statement that I've seen written is if there is no decrease in efficacy, then there are no anti-drug antibodies. Again, Why waste time and money in testing them? If the anti-drug antibody titers are low, there are no neutralizing antibodies. And finally, baseline anti-drug antibodies are not important. Another way that I've seen this statement is exclude these subjects who have baseline anti-drug antibody positivity, from the analysis because it's not truly an anti-drug antibody because they were there at baseline. So with the talk on interpretation of immunogenicity in the YouTube series, I hope that I can go through all of these different questions and explain why, in my opinion, these are mistakes and these are not trivial mistakes. These could actually have some sort of rationale behind it, but when we look at the data, when we understand the biology, we realize that we have to really avoid making these mistakes, look at the data and draw the conclusions in every single study we look at, or if you're looking at your patient on an individual basis, what is happening there. And don't get stuck with statements that could be mistaken in that particular setting.
There are several regulatory submission guidance documents that are very useful, even if you are looking at the results to interpret some data from your patients. These guidelines are extremely well written, very thoroughly, studied and researched, and they actually explain a lot about how should we consider these immunogenic responses to drugs. So there are several things that FDA and EMA, so the Food and Drug Administration is the key regulatory agency in the United States. There are many countries that follow FDA guidance and decisions. And the European Medicines Agency covers a lot of European countries, and again, there's many other countries in the world that follow them. There are some other regional regulatory requirements, but in general, for immunogenicity, they are very much covered and represented in the general concepts that I'm going to explain here from the FDA and EMA. So what are the things that are in common? They all say, whenever we are looking at therapeutic drugs, and these are guidelines for new drug approvals, but nevertheless, if you're looking at effects of a drug that you've been using and you want to understand better the immunogenicity aspects of it, these are very good guidelines that help understand the basic science behind it and the rationale behind interpretation. So one of them is they all have immunogenicity specific guidelines. So for proteins, for therapeutic drugs that are proteins, they can all be immunogenic and they can all cause immunogenicity, and they have a very good explanation on why these guidelines apply to all of them. They also identify preclinical risks. So what we mean by preclinical is data in either cell-based assays or from the characteristics of the drug in the laboratory. That could be chemical attributes. There might be some risks on potential chemical attributes that could be causing an increased potential for immunogenicity responses in humans, and also could be from animal models. And then in the humans, how do we manage this risk? So if we understand the potential for a particular drug to mount an immune response, what do we need to do with patients once they are exposed to this particular drug? So the FDA immunogenicity assessment, I literally just copied pasted the table of contents. And I encourage you not to look at any particular guidance. I am actually taping this in 2018, and I am using the latest guidance that it's available. However, these guidances are constantly updated, and they have new information. There might be new methodologies or new knowledge that can impact all of these guidances. So this is just an example, and you should look for the most current version of these guidelines if you're interested in looking at them. But what I want to just highlight is that in the table of contents for the FDA, they say, we need to understand in the risk factors what are the patient-specific factors that can affect immunogenicity. So this is from the population and the patient standpoint. Is this patient capable of mounting an immune response? Or is this patient a patient that has an immune system that's compromised? And it could be compromised because of either the disease that the patient has or the medications that a patient is receiving. So if you're looking at potential immunogenicity in a population of patients with cancer, for instance, who are taking heavy chemotherapy, you might not see the full immunogenicity ability of the drug or potential of the drug if you're looking at this population. So it is very important to understand from the patient standpoint what are the different potential risks that you have for immunogenicity. And as you can see there, it's the immunologic status and competence, as I explained. Has the patient been previously exposed or received a particular either drug or drug product? So is there any history of allergy to any of those? What is the route of administration? What's the dose? What's the frequency of the administration? All of that has to do with the response of the immune system to the drug. There might be some cases with genetic predisposition to a particular immune response. And, what is the status of the immune tolerance to endogenous protein? So in part 2 of this series, I did explain a bit about the importance of having a drug that could be an endogenous protein. And if you have an immunogenic response to an endogenous protein, this can carry consequences in terms of safety of the patient. I believe I also mentioned a little bit on part 1, but basically you can find more explanations on this specific on part 1 and part 2. But for part 3, what we need to focus on is the fact that if we are looking at a drug that's an endogenous protein and it is immunogenic, it can have consequences on that patient that go beyond just the drug administration. You can always discontinue the drug if there's a particular problem with immunogenicity. But the problem is if your drug is an endogenous protein and now the patient has mounted an immune response to the endogenous protein. So you're given insulin, the patient reacts with immune response to that insulin that you're giving the patient. You can stop the treatment, but maybe the immune response is now reacting to the patient's own insulin. This can happen with many different kinds of proteins. So it is important to understand what is the status of that immune tolerance to the endogenous protein. And you should read the package insert of the drugs you're using to understand all of these aspects that are important in immunogenicity. And then there are product-specific factors. So you have patient and product. So from the product standpoint, the type of product, formulation, chemical characteristics, biologic characteristics, physical characteristics, all of them are super important because they can all trigger a potential immune response in a given patient. And the most important thing is that, ultimately what we need to understand is if the immunogenicity of that particular drug is having any consequences on efficacy or consequences on safety. When you look at the European Medicines Agency guidelines, again, this is the one from 18 May 2017, We're now in 2018, and these are the latest ones that are available, but these are documents that can get updated at any time. But basically what you see is, again, there's the highlight of understanding what are the risk factors that can predispose an immune response, and it's from the patient standpoint and the product standpoint. So it's different in order of where the FDA requires their package to be, but they both talk about the same thing. Understand the risk factors from the patient perspective and from the product. And understand were there any consequences on efficacy and were there any consequences on safety. And this is talking about the whole immunogenicity. So in terms of the consequences of the product, is important to understand if they also affect the pharmacokinetics, not only safety and efficacy. This is also included in the FDA recommendation. So bottom line, the two agencies have a lot of things in common, and they both recommend understanding the risk factors from patient and product, and also understand the consequences that the immunogenicity are having on efficacy, safety, and PK. So from the FDA assessment, when we're talking about safety, it is very clear that the agency, when we talk about anaphylaxis, which is a serious adverse event, the agency relies on several different diagnostic criteria, but they strongly recommend using the Samsun criteria, and I will be explaining a bit more about what the Samsun criteria is. As a clinician, if you have a patient and you're going to dose that patient, understand the potential immunogenicity reactions when you read the package inserts, understand what would be expected, and make sure that you follow that patient. You keep the patient in observation depending on the drug that you're using, if there's some anaphylaxis seen with the drug, and make sure that you can capture any potential signs and symptoms. For the drug approval, the agency, the FDA, is expecting to see the Samsun criteria applied, which I will explain later, but from an individual standpoint, you can actually look at any kind of potential adverse events of interest to analyze this potential anaphylaxis to the drug. A very important thing is anti-drug antibody alone is not necessarily predictive of an immunogenic response, especially anaphylaxis or other hypersensitivity reactions. So this is critical. Having a patient who has no anti-drug antibodies does not tell you that there was not an immunogenic response. We need to make sure we look at the whole manifestation of immunogenicity with or without anti-drug antibody present. In the European Medicine Agency, what they want to see is an integrated analysis of the clinical significance of the immunogenicity. So basically, when a sponsor is presenting a program, there are many different protocols, trials, and results, and what the EMA agency is expecting is seeing a standalone document that has integrated analysis of the immunogenicity but clinical significance. So what they focus on is not just was there immunogenicity or not, but what was the clinical significance if there was any immunogenicity. So that's the important thing, is clinical significance. And in this integrated document, they want to see effects on pharmacokinetic, pharmacodynamic, clinical efficacy and safety. So not just saying this is the immunogenicity response and that's it, but was there an effect on any of these particular parameters that was of clinical significance? So there are key elements that differentiate the two approaches, but there's more commonalities between them than differences. The specific differences is, as I mentioned, the European agency is for now requesting or expecting an integrated summary of immunogenicity as a standalone document. Even though the FDA has not yet, as of the guidelines in 2017, requested it or expected it, all of the elements in the integrated summary of immunogenicity that the EMA is expecting are also expected by FDA. They could be in different documents, they could be in summaries of efficacy and then have a section on how the immunogenicity was impacted, summary of safety, and then have a section on the immunogenicity. And they definitely are singling out the Samsun criteria used for analysis or assessment of anaphylaxis, which the European agencies basically says, remember to make sure you consider the potential anaphylactic reactions, but they're not telling us to use the Samsun criteria. So when we are looking at hypersensitivity responses, we need to remember what are the different ones.
In type 1 hypersensitivity, let's remember what is the mechanism behind it, and it could happen in an anti-drug, in an immunogenicity response to drugs. So what you have is a particular, in here you have an allergen, but this could be the drug, and you have a co-stimulatory signal between the cell that is presenting it to the T cell, and you have a CD4 co-stimulatory signal with production of interleukin-4. For more detailed explanation of this particular IL-4 cytokine-driven TH phenotype, which is the TH2 type, please see other YouTube videos that I have on TH phenotypes. So when the particular interaction drives a TH2 response, this interleukin-4 is going to stimulate not just the B cells and mature them, but also stimulate or promote the isotype switch. The isotype switch generally goes in order from the IgM, which is the less mature. It moves on to IgG with different subtypes, then IgA, IgD, and then finally it super matures to the IgE, which is the most switched of these isotypes. Together with the isotype switch, the interleukin-4 response is going to trigger a lot of different cytokines. Among them is more interleukin-4, interleukin-13, interleukin-33 is also involved, and interleukin-5. And they have effects on different kinds of end cells, like the smooth muscle, blood vessel, mucous glands, platelets, sensor nerve endings, eosinophils, and basically there's a lot of vasoactive amines. So this vasoactivity is going to produce the typical allergic response that we see when we have a bee sting, when we have these very extreme allergic responses. An allergic response of this type 1 hypersensitivity could be serious when it's elicited against a drug. So it is very important to understand. If we are not measuring isotypes, at least we do understand clinically, is this patient having atypical type 1 hypersensitivity, hives, sneezing, itchiness, and all of the typical allergic responses that are characteristics of the type 1 hypersensitivity should be analyzed when we have patients that have exposure to drugs that could be immunogenic. Type 2 hypersensitivity is the hypersensitivity that has the component of the antibody-dependent cytotoxicity effect, or the ADCC. In part 1 of this series, I explained a bit more about these different effects of the Fc portion of antibodies. But it is very important that the complement dependent, so the CDC, effect is involved in cell lysis, for instance, when we have a blood type incompatibility, and we all know that's a very serious situation. It's also present very much for red blood cell degradation in terms of Rh incompatibility. And ADCC triggering can also be produced by this immunogenic response. So we need to understand if our drug is having a type 2 hypersensitivity. It could be serious. Now, on part 1 of this series, I did explain that some drugs that we have in the armamentarium can actually bind the receptors, and part of the mechanism of action is to produce these effects. So the typical example is rituximab, where part of the mechanism of action is to trigger CDC, ADCC effect on the lymphoma cells and kill them. But depending on the drug that you have, an anti-drug antibody could potentially increase these Fc effector functions and have a serious manifestation that depends on what is the membrane target or the membrane receptor that is used in the particular drug. So if you have a growth factor and you have antibodies to that particular growth factor, you could be causing cell lysis on the cells that bear that particular receptor. And that's what you need to bear in mind. Where are these cells binding? What is a target cell that the system is binding your drug? And if you have anti-drug antibodies that could be producing a type 2 hypersensitivity, what is the kind of clinical manifestations? Is this going to be anemia, or is this going to be neutropenia? It depends on the cell that's targeted by the drug. So make sure that you also follow this type of hypersensitivity reaction, which is an immunogenic reaction to the drug. Another type of hypersensitivity reaction that we need to understand and follow in our patients that could be in response to a drug as part of the immunogenicity response could be with the formation of immune complexes and activation of the complement cascade. And this is what we also know as serum sickness. The time of appearance in this graph is on days after the drug has been administered. In this case would be the drug is the antigen. And so it is very important that we capture potential signs and symptoms of this it could be a very serious hypersensitivity reaction with very notable mast cell release of histamine and via the complement activation. So again, this is a very important disease. Is systemic. In this case, is not going to be seen as an injection site reaction or an infusion related reaction, but it could be generalized, systemic, and very, very serious. Hypersensitivity type 4 is a typical cellular response. It's not mediated by antibodies. So as I had mentioned in the past, immunogenicity can occur against any therapeutic drug that's a protein, and it can be just basically innate system response, or it could be the adaptive system. And if it's the adaptive system, it does not necessarily have to have anti-drug antibodies. And this is one of the type of hypersensitivity where there's no anti-drug antibody. It is mediated by typically a Th1 response. And again, I encourage you to watch other one of my videos in the YouTube series on Th phenotypes. So basically, what happens is it is not going to be a bacteria, but it's going to be the drug is presented by the antigen presenting cell, and it triggers a Th1 phenotype, which is very much characterized by the production of TNF, interferon gamma, and also interleukin 2. And the triggers for this particular phenotype are interferon and interleukin 12. So in this particular kind of reaction, you can have a lot of different clinical manifestations of an immune response with inflammation, with a lot of response in terms of it could be pain, inflammatory response. You can have the activated macrophages producing also killing of the cells that are carrying the drug in case that the drug is cell surface. So you can have a lot of different consequences secondary to this particular Th1 response. So it is very important to look at all the potential signs and symptoms of hypersensitivity and remember that they can be delayed hypersensitivity. So if a patient is referring to any kind of signs or symptoms that can be attributed to hypersensitivity 2 weeks after the drug injection, don't discard it. It could still be a delayed hypersensitivity to the drug. And you need to make sure you actually follow that patient, especially if there's a need for a future drug administration. Make sure that you carefully follow the patient and observe the patient to see if this was truly a reaction to the drug or not. I want to discuss a little bit the Samsun criteria because not only the FDA has been expecting to see it when there's a result, but it's important if you hear about the Samsun criteria, is it something you can use in the clinic or not, and how would you use it in the clinic? So Samsun published this paper in 2005, and basically it's a paper that helps determine anaphylaxis, and it is cut pasted from the paper. Anaphylaxis is highly likely when any one of the following 3 criteria are fulfilled. And so there you can just read as well as I can. Criterion number 1, it does state an acute onset of an illness with involvement of the skin, mucosal tissue, or both, and at least one of the following. So respiratory or some, reduced blood pressure or symptoms of end organ dysfunction. So criteria number 1 is something that you will actually see minutes to several hours. So for Samsun determination of potential anaphylaxis, this is agnostic of the antigen. And what is happening is you have a particular patient, that patient might not be aware of an exposure to an antigen. But in the case of a drug exposure, they do know when they receive the drug. However, we don't know if that drug is immunogenic. So if minutes to several hours later, a patient's developing these symptoms, it could be at the site of the injection, it could be erythema, could be pain, it could be hives, it could be itchiness, and then they also are wheezing or having respiratory compromise, or they have, blood pressure, they have dizziness, they start collapsing. you do realize that's a potential anaphylactic reaction to the drug. So many of the drugs that are administered to patients have to be in the presence of a health professional, care professional, at least for the first injection, so that you have an idea how the patient reacts to it. Criteria number 2 and 3 are iterations that require different conditions. You can read them as well as I can, and I just encourage you to take a look at them, see if you feel comfortable having them handy for when you are treating patients, understand if there is a potential anaphylactic reaction. And again, for the Samsun criteria, these are within hours of the drug administration, which is not the case for hypersensitivity. So just remember, for anaphylaxis, Samsun criteria, it happens fast. For the other kinds of immunogenic reactions, we can have delayed reactions, and we should not discard them only because they are being presented or reported days after dosing. So what is the clinical data that we need to use for interpretation? We do have anti-drug antibody results. I explained this in more detail in part 2 of the immunogenicity series. So how do we get these results? It is important to know the number and percent, if you have a study, of patients who are anti-drug antibody positive. That's useful. It is useful to tell you how likely is a particular drug to mount an antibody response. But it's important also to know what was the onset, what is the duration of that anti-drug antibody in blood, what are the titers. If isotypes are available, it's also good to know and understand how to interpret them. If not, I think titers are good enough to indicate if we have primary responses or worst case is secondary memory responses to the drug. In addition, we can also identify if there were several assays for anti-drug antibodies, is there any cross-reactivity? That might be relevant if you are changing from one manufacturer to another to understand if these antibodies are going to cross-react between the two drugs or not. So in terms of anti-drug antibody results, it's important to understand what you're getting and not just look at one single result. In terms of neutralizing antibodies, it's also important to understand how they are detected, the titers, and if there's any cross-reactivity or not. In terms of neutralizing antibodies, they might be a subset of the anti-drug antibodies, or all the anti-drug antibodies present could be neutralizing. And so it is important to follow the titers because you will also be able to determine if the neutralizing antibody is presenting with a primary response or a secondary response that actually has memory. The identification of true versus false positive results is really not in scope for a clinical interpretation. You should be getting from the laboratory a result, and maybe you want to also find out in a particular assay used for a particular drug what is the likelihood of a true positive and a true negative results. But in general, you're not supposed to be able to draw the conclusion from what you just see. So what you can see from the results are the time, you know, when the patient was dosed, the titers, and if there's any cross-reactivity. You should also be able to identify how the anti-drug antibodies can impact or not safety on the patient. So when we look at immune-based adverse event, what we need to really pay attention to is local. So it's infusion-related reactions or injection site reactions. And this is, as I mentioned before, same as when looking at hypersensitivity type reactions, you also are looking at the potential fulfillment of Samson criteria for anaphylaxis. So you look at hypersensitivity, anaphylaxis, or allergy, and this can be related directly to the drug when it's being administered. And this then you can actually analyze if there was any drug antibody present or not. Now, the interesting thing here is that once you have the results of the anti-drug antibodies, you can see if the antibody anti-drug is actually predicted symptoms, signs and symptoms of infusion-related reactions or injection site reactions, or the anti-drug antibodies can be a consequence after you see the manifestations occur. So anti-drug antibodies may actually be preceding or be after the clinical manifestations, and that's why you should analyze the manifestations independently of the anti-drug antibody results. The potential hypersensitivity and anaphylactic reactions in clinical trials can be done with systematic searches using computer and either dictionary. It's one of them used is the MEDRA dictionary. So you can use a medical dictionary for signs and symptoms that are associated with hypersensitivity and anaphylaxis. And when you have a database and a study, you could do a systematic search or query for those and identify them. Generally, this is done retrospectively. Alternatively, you can have a list of potential hypersensitivity reactions and anaphylactic reaction signs and symptoms of them in your office, and you can see if the patient is having any of those manifestations. But remember, these could be delayed, and it would be unusual for you to have a patient in-house for so long after drug administration. So it is something that's important to note if the patient comes back and tells you about any kind of manifestation that could fall within this category. You can also retrospectively assess and then make sure that on the next administration of the drug, you follow very closely if the patient truly has an immunogenic reaction to the drug or not. The Samson criteria algorithm is for you to use. I mean, you can read it, you can follow it manually, and you can use it in individuals, or you can use it for a whole database. And the three different areas could have a more comprehensive analysis of the impact of immunogenicity on safety rather than just using one or another. The impact of anti-drug antibodies on the pharmacokinetics, and if there's a pharmacodynamic effect of the drug, you can also see it. For instance, if you're using a growth factor for neutrophils, you can see the pharmacokinetics of the growth factor, but you can also see the response of neutrophils in terms of growth and more neutrophils from the drug. And if you have anti-drug antibodies, you can see if these are actually interfering, either increasing or decreasing PK, or affecting the pharmacodynamic measure. For more details on how the anti-drug antibodies could affect the PK, please look at series part 1 of this immunogenicity interpretation series. Finally, the impact of anti-drug antibodies on efficacy is also important. If you can take a look at this, would be more in populations. It would be difficult to see on a per patient basis unless you have a particular effect on a PD marker that's very critical, you can actually see if the efficacy is being lost by patients developing anti-drug antibodies, and then the drug is rendered not efficacious. So those are important things you need to consider when interpreting immunogenicity. There is always the case where a drug could be immunogenic, could be mounting a humoral response with presence of anti-drug antibodies, and these anti-drug antibodies may have no effect on safety, no effect on PK and PD, and no effect on efficacy. So it is important for you to understand that ultimately what's important is the effect or the lack of effect that potential immunogenic responses can have in the patients. To create this particular file and the animations and the cartoons, I have consulted many different literature reviews and different papers, but these are the ones that I would highly recommend, and I will put them in the YouTube description. Thank you for listening.